evening, everybody. Good evening, good evening. I'm just going to stand here for a minute till I get everybody's attention, and then I can step away because I know you can hear my voice without this. Yes. Thank you. So, firstly, I want to thank you all for coming to our first program of 2014. And so you know, for those that don't know, my name is Stuart Schlossman, and I'm president and founder of MS Views and News. We provide educational programs for those affected by multiple sclerosis. We started this in 2010, and since 2010, we've now done over 80 programs. For tonight's program, we must thank Questcor Pharmaceuticals and CVS Caremark for giving us the funding to do tonight's program. Each of our programs, thank you. Each of our programs are provided by pharmaceuticals or other corporations that know the need for us to be talking about multiple sclerosis. So they ask us to do these things. We ask them to fund us. We get the funds, and we are able to provide these programs. We also want to thank tonight our pharmaceutical sponsors that are our display sponsors. And here in attendance tonight, we have Genzyme, a Sanofi company, and we have Bayer Pharmaceuticals, or Bayer Healthcare, right? Okay, Bayer Healthcare. And so in addition to them, though, others that were supposed to be here but couldn't be here tonight for one reason or another are Novartis, Questcor, and Biogen IDEC. And so I want to thank them all for, helping us out as well. So tonight's program, for you all to know, we are going to have Dr. Gold. Many of you probably have heard Dr. Gold. Others have not. He does a great talk. After he speaks, we're going to do Q&A. And when we do Q&A, there'll be a microphone going around the room, so please wait till we get the microphone to you. We're not going to show your face. We're not going to video your face, but we will be able to hear your questions, so that way, again, whoever's listening to this program will be able to hear the question and hopefully hear a good answer. All right? So we're going to do that with Dr. Gold after he does the presentation, and then after he's finished with the Q&A, then Jeff will begin with the adaptive exercises for MS. And again, for anybody that wants to volunteer to come up and do this with Jeff, he would love to do this. And if you don't volunteer, he's going to pick you out. So you better just find a few of you that want to come. Draw straws or something. All right. So without going much further, because I can stand here and talk all day, before Dr. Gold begins, every time we go to a new area, we always ask a support group leader or leaders to come up to the room and come up to the front of the room and discuss what they're doing in the community as well. So tonight we have Richard Schilling from Port St. Lucie. No? Where are you from?
Fort Pierce.
Fort Pierce. I was close.
Good. I hope, I too, you should be able to hear me fine. As Stuart has said, my name is Richard, and the last name is Schilling. I'm an advanced practice nurse who retired from the VA system. When I came to Fort Pierce, there was a small support group that was started and running and doing quite well. And they asked me to become the facilitator shortly thereafter. Our support group is the MS support group of the Treasure Coast. We serve Indian River, Okeechobee, St. Lucie, and Martin counties. We have about 300 people who are members of our support group, whether they attend actively or not always. Our support group meetings are about 25 strong who attend. We meet the first Thursday of every month in the Port St. Lucie Community Center on Aroso. We meet from 10:30 to 1. During that time, we focus on an educational presentation. We do not have a doom and gloom support group. I know some of you have probably attended a doom and gloom support group, where a few people sit around a table and just talk about what's happening in their lives. Because I'm a nurse, and because I wanted us to learn and become empowered, I focus on that issue. And there are support group members here tonight. I believe there's several that you can talk to also. That's all I wanted to say. Again, it's the MS support group of the Treasure Coast. We are supported by the MS Foundation in Fort Lauderdale, and we meet the first Thursday of every month. Thank you all.
Thank you, Richard.
Thank you, Stuart.
Thank you. You're finished. Thank you. So, again, before, though, Dr. Gold comes up, I want to tell you all that we are doing a raffle item tonight. We do this at a lot of our programs. Why? Because we want you to come for the raffle item. No. We really like to have you here, all right? And we love seeing a full room, and this is great for our first time in Vero Beach. And I personally can't wait to come back and do another program. So After everybody is done, we're going to make you wait for the entire program before we do our raffle. How's that? And if you really don't want the raffle item, by the way, it's a gift from the Quilted Giraffe for a dinner. And so we'd love to be able to do this with you later on. Now, Dr. Gold, come on down. The price is not right.
Okay. I'm going to try to keep this short, number one, to keep my voice. Number two, so we can get to hear Jeff, who gives a terrific presentation, and you can all join in. And number three, because I don't want to put you to sleep, at least not right away. So if anybody cannot hear anything, or if they don't understand something I've said, just let me know and I'll repeat it. During the question and answer session, I will repeat the question so everybody can hear, and we'll go from there. This is going to be an interesting time. All right, first of all, someone asked me about what ECTRIMS stands for. Does anybody know besides this group here? Okay, it's the European Committee for Treatment and Research in MS. And it's one of the largest groups specializing in MS treatment and research throughout the world. I was lucky to attend that meeting. I'm not going to tell you the name of the town, but I'm going to show you some pictures and we'll see if we can get some correct guesses. The meeting comprises over 800 physicians, neurologists from all over the world, people from every part of the planet that you can think of. And it's really fascinating. They accept research from all over the world, but it is predominantly from European countries. There's also an American version called ACTRIMS, a Latin American version called LACTRIMS, and next year's meeting, actually this year's meeting, is going to be in Boston, so it should be an interesting time. Okay, let me see by hands how many people have had MS for more than 1 year. Okay, so quite a group. Anyone been to lectures like this about MS in general, not specifically about particular pharmaceutical drugs? So a few, okay. So we will cover a lot of territory very quickly. I want this to be for you, not what I think you should hear. And so if you need to stop me, ask a question, that's fine, but try to hold most of the questions towards the end. First of all, any guesses as to where this past year's European meeting was held based on this picture? I hear Holland, Copenhagen. Anyone else? Okay, let me show you some of the other pictures before I give away the answer. This looks like Amsterdam in terms of the style of the homes along the canals and so forth. Similarly, you have some beautiful homes along the way. There are shops and the boats that take you everywhere. Every single European country seems to make its most impressive buildings the performing arts buildings. And so this was in the downtown part of the city. This will be a little bit of a giveaway. This is an amusement park where they hold all kinds of activities as well as have rides and so forth. It's called Tivoli Gardens. And this was actually one of the first times that they've celebrated Halloween. And so we happened to be there in late September, early October, and they were just starting to open this up for the kids. But for everyone else, they had to pay a little extra. It really closes October 1, and so we didn't get to see the park, but we got to see and take pictures of people parading through. And of course, the national treasure of this country is the Little Mermaid. Anyone familiar with this statue? Okay. So this is Copenhagen and Denmark, and it's a beautiful country if you ever have a chance to go. Luckily, I was able to go as part of this meeting. Of course, I did have to drag my wife along, which she was thrilled with and I was thrilled with, so it was a great time. So this was where the meeting was held. In fact, this is the second time the meeting was held there, and it's a very popular place for meetings in general, but also for spectators and travelers. And this actually happened to be the Queen of Denmark, who paid a visit to us and made a presentation during the research meeting. And there was also, you can see some drums there below the picture of her. There was actually entertainment there too, so it's not all boring research. These are just some of the disclosures and companies for which I've spoken for or provided research. Okay, let me just adjust this. Very good. So this is going to be our agenda for the night. I've kept it fairly simple to try to get through a lot of material, and it'll seem like we're rushing through a lot of it, but I'm just going to hit the highlights, and we can cover any details that you want to cover in the Q&A. So the first thing is to review some of the research on the cause or contributing factors in MS. Okay, and we know a lot about MS, but we're also learning about what it is and what it isn't, and so there's still a lot to be learned about what's causing it and what's contributing to it. We know it affects different parts of the central nervous system. It's an autoimmune mechanism, meaning that the body's immune system is attacking certain nerves. There's inflammation in the myelin, causing destruction of both the coverings around the nerves as well as the nerves themselves. And this leads to, eventually, if it's unchecked, permanent neurological dysfunction. We used to think that this was strictly T-cell lymphocytes. We now know it's B-cell lymphocytes. The bottom line is there's lots of research being done to try to augment or at least try to modify these aspects of the immune system. And this just shows the myelin sheath. The oligodendrocyte is what forms the sheath around the nerve filament. And these activated T cells come in and secrete cytokines which cause the destruction and eventually takes away the myelin. Now, during the early phases of the disease, as we know, people have a remarkable ability to remyelinate or repair their coverings around the nerves. So we take advantage of that and we try to get started on treatment early that will reduce the inflammation and try to reduce the long-term effects. Okay, we still don't know a precise cause. People have postulated that it could be viruses. There have been dozens, if not hundreds, of viruses that have been implicated, and none have panned out because it's not the same virus for every person. It seems to be a group of viruses that occur in different people with the genetic predisposition based on the immune response. Northern climates seem to be important. The Epstein-Barr virus seems to be more of an issue in northern climates. Excuse me. Vitamin D has been playing a bigger role as we've learned more about how it affects the immune system. There's also some postulates that even some of the retroviruses like HIV and so forth might have a role in the immune system and autoimmune diseases, but that's still in its early stages. So a lot of things that are in early trials and starting to get worked out a little bit better as we go along. Age seems to play a role. So if people have had the disease for a long time and they're older, and then the disease can accumulate and we don't repair as well as younger patients. But that's not the entire picture either. Vitamin D, we think, plays a role. It seems to affect inflammation. In fact, the genes that code for vitamin D and the genes that code for the HLA antigens, which are the autoimmune antigens, are right next to one another on the chromosome. And so there seems to be a close correlation there. It's very interesting. Okay, so other factors. We know that sleep can play a role. People just assume that fatigue is an intrinsic part of MS, and it may very well be. It may have an autoimmune mechanism. But we also have to think of things like obstructive sleep apnea, which can lead to fatigue as well through sleep deprivation. And it's estimated in one study at the meeting that up to 68% of people would have difficulty with obstructive apnea. And this can be treated although not easily, can be treated and corrected. There was some information presented on high sodium intake and high sodium levels, and that seemed to play a role as well. But it's, again, one of many factors, not the predominating factor. Pregnancy, we've used to think was a problem with MS patients, and so there was at one point decades ago when people were discouraged from having families. It's now known that the actual incidence of the attacks drops during pregnancy, particularly in the third trimester. So you can see the pre-pregnancy annualized relapse rate of 0.7 drops down to 0.2 by the third trimester, and then it skyrockets up to 1.2, up 6 times from pre and postpartum periods. So it's pretty dramatic, and we don't know all the reasons. We know that estradiol seems to play a role, but we don't know all the reasons. But we do know that women can have families. We look at them more closely in the postpartum period and consider medication around that time to try to prevent some of the rebound effects that occur afterwards. Okay, this is some information about predicting the course of MS. There's something called CIS, or clinically isolated syndrome, where you can try to predict what people's prediction will be to develop more definite signs and symptoms of MS. And about 60% of people overall, if you follow them for 2 years, if they have a clinically isolated syndrome, will go on to develop clinically definite MS. If they don't have all local clonal bands, if they don't have T2 lesions on their MRI, and if they don't have both, then the rates drop significantly below that. So those people who have relatively low rates of progression to MS have the lower incidence of either the T2 lesions by MRI or the oligoclonal bands in the spinal fluid. So those can be used as good predictors for the future. There's also a phenomenon or a diagnosis of benign MS, and people have tried to decide how to determine who's benign and who isn't. And the traditional definition for benign MS were those people who had disease durations of over 15 years and their EDSS or disability scores never reached a significant level. They stay below 3.5, which is in the mild to moderate category. And people were still ambulatory, still able to walk long distances, and were able to function very well. But then if you looked at patients over time and you retested them, this is a study of 163 patients done by one of the European Union countries, and looked at those patients later on, you could see that almost half the patients had cognitive impairment, over a third had cognitive impairment sufficient to reduce their work or social activities. Half the patients had fatigue and half the patients had depression. So it's really not as benign as you might suggest. So you do have to take that into account when you're deciding about whether to start therapy or not. These are patients without treatment. Okay, these are other predictions. I'm not going to get into a lot of detail. There are certain biomarkers that we can use in spinal fluid to predict how people are going to do in the future. You can also go online. It's not very easy to see. Go to msprediction.com. There's a nice little tool where you can predict what your risk of developing progressive MS is in the future. You just plug in things like your age and your number of relapses, when your last relapse was, how full of recovery you made, and you can come up with a little number that gives you a little bit of a predictive value of progressing in MS. And it's certainly not foolproof. It's not as accurate as you'd like. It's based on populations out of Canada, which may not be applicable to the rest of the world, but still it's kind of a nice little tool to try. Okay, new ways to assess the disease and its progression. Traditionally, we've tried to divide people up into different subtypes of MS. And if any of my patients know, I tell them just throw this right out the window because it doesn't help predict how to treat a given person. And we use these categories, the relapsing remitting, relapsing progressive, primary and secondary progressive, to help us for research trials and it really doesn't have much utility in clinical practice. But the first question people ask me when they come in is what type of MS I have. And so I said, you have your own type of MS because everyone's so different. So even though we have these broad categories, there's tremendous variability within those categories. And part of that is because the genetic process is very complex, and everybody's genes are very different. Everybody's exposures to viruses have been very different. So there's just too many variables to make those kinds of predictions. But even knowing that, those patients who have relapsing disease have about a 2 in 3 chance of going on to developing secondary progression without treatment. The one category called primary progressive is very rare. It's probably about 5% or less. Okay, so we can monitor patients based on their disease activity, based on their response to medication. And we use different things like the history, their relapse progression, how severe their relapses are, how much recovery they're getting, how far apart they're occurring, whether they have to have steroids as a treatment for it. So there's different ways to gauge how severe their relapses are. We can also use other things like the neurological examination, some other tests that you can see there, the EDSS and so forth, gives you some broad estimates as to how to monitor people over time. None of them are perfect, and it's good to use a little of each. The most important thing seems to be the history and the exam, like it has for most of neurology for probably 500 years. Other ways, such as neuropsychological testing, can help. The MRIs, of course, can be very helpful. Evoked potentials, OCT, which is the eye testing, both visual acuity, visual fields, and so forth. Vitamin D levels, and quality of life measures as well. Some things that were presented at the meeting were different types of computerized programs that would enable people to be able to test their mental processing and so forth, so that was very helpful. Some of the current therapies. Now, obviously, we can't get through all the therapies in the allotted time, which is about how much time? About another 15 minutes or so. So we'll try to get through the basics, a little bit of each medication. The goals of treatment have not changed very much. We have to keep those in the forefront of our minds. But preventing relapses, treating the relapses, trying to keeping the severity of the relapses under control, learning to recognize what we call pseudo-exacerbations that look like relapses but are not, and therefore aren't treated the same. Trying to manage the symptoms that occur both during the relapses as well as between relapses. And then trying to delay progression of disability and stabilizing or improving the MRI. We also know that timing of therapy is critical. So those people who have no therapy have the natural course of the disease, but when you start treating, even if it's a little bit late, we still see significant improvement in disability. And if you treat earlier, and the earlier we see treatment, the more effective the results are for limiting disability. This is just to show variability that can occur within MS patients. You can see a lot of differences. These are actually very similar slices left to right, but there's a big variability from one to another. And if you follow patients with time-lapse photography, and you can go online and look at that, you realize that it's a very fluid disease. It's coming and going, enlarging and decreasing. We're taking snapshots ordinarily once a year. These were done as part of a study that we're doing them every 2 to 4 weeks, so you can see the changes occurring very dramatically. The other thing is that you can see atrophy that can occur over time. And if I can get it to work right, you'll see that this is starting from an early phase, and you get more and more shrinkage over time as the brain shrinks down and loses tissue if you're not treating the MS long enough. And you can see two things happening. Number one, these crevices in the back here are getting larger around the surface as the brain tissue is shrinking. and you're getting loss of tissue around the ventricles, so the fluid-filled spaces are enlarging. And this doesn't happen with the vast majority of our patients to this severity, but it can occur, especially if it's untreated, and especially if someone has a pretty aggressive form of the disease. So it can go from mild to severe, but you do have to try to treat early if you have a fairly aggressive form of the disease. Some of the general guidelines for treatment can be starting with the non-pharmacologic treatments, such as diet, and I've listed some things up here that you can look into: the diet, the vitamin D supplementation, exercise, stretching, weight training, aerobic conditioning, all can be very helpful, and Jeff's going to give us a nice review of that. Sleep quality and quantity is critical. Planned rest periods, relaxation exercises, biofeedback, a number of things can be helpful. Tai Chi and yoga. Foreign substances are to be tried and not necessarily eliminated 100%, but at least minimized, because they do take a toll over time. And we're finding that more people who smoke cigarettes have a higher risk of developing secondary progressive MS. So we do need to heed those kinds of research findings. The coordination, we try to look at actually different factors that may mimic or aggravate the MS symptoms. So always be aware that just because everybody says that it blames everything on the MS, it may not be, and you have to look at other conditions as well. Some of the symptomatic therapies that were discussed at the meeting, there's one called Sativex, which is THC. Everybody knows what THC is, I assume. It's put into an oral mucosal spray and then inhaled. And there's an average, when they did the studies, people required about an average of 6 sprays per day. There's a small group over on the side that did it continuously, but we had to throw those people out of the study. So, but most people tolerated the medication very well. They didn't have the severe side effects that people get when they're using high amounts of regular cannabis, partly because you avoid some of the negative effects of inhaled smoke, but you also can see cognitive impairment that occurs long-term in smokers of marijuana. So using this kind of purified form in an inhalant form does not have those kinds of side effects. It does seem to help with spasticity in particular. It may help with pain, although that was not studied in detail. Okay, so some of the traditional therapies we talk about are treating the individual attacks acutely, such as with IV steroids, Acthar, and so forth. When those fail, you can, or if those fail, you can look at other therapies as well, such as plasmapheresis, IVIG, and immunosuppressant therapy. The bottom line is if someone has a very aggressive form of the disease or a very aggressive attack, then you want to tailor your treatment to that particular aggressive disease. So in other words, you may have to use stronger and stronger therapies to get the same results compared to someone who had a relatively mild exacerbation or mild form of the disease. You can see that over the last 20 plus years, there have been a number of medications that have come out, beginning with beta-seron back in the 1990s and moving all the way over to some of the oral drugs. We're going to go through a little bit of that, but the original drugs that came out were proven safe and effective and became the traditional platform therapies, is what we call them in the United States. In Europe, they call them first-line therapies because they discourage people from using other therapies unless they've tried and failed some of these original therapies. So a little bit difference in philosophy. I think both in the United States as well as in the European Union, we're looking for ways to try to minimize side effects, find out which people are not going to respond well, and get them switched to the right drug. And so we're evaluating patients more aggressively and earlier with MRIs and exams to try to determine if they're on the right drug or not. And that way you save money by not keeping someone on a drug 1 and 2 years, which has been the traditional way of approaching it. And I think that has quite a bit of a value to it. we also have to try to figure out a way to pay for some of these drugs. And if someone's not doing well with one therapy, finding ways to pay for some of the other more aggressive therapies as they come along. And that's a real challenge here and around the world. There's something called step therapy that started out when there were basically about 3 or 4 drugs. That was through Dr. William Stewart in Atlanta. And basically you started with one of the platform therapies, and if someone didn't tolerate it or they didn't respond to it, then step 2 means that you would switch to one of the other platform therapies, and you do this repeatedly if you had to. By step 3, then you start adding therapies on top of this platform therapies or the first-line therapies. So you would add either steroids, Acthar, or even some of the immunosuppressant agents, which adds to the benefit of the traditional therapy. So we try to find ways of, number 1, making sure people can tolerate the drug. Number 2, finding ways to determine if they're responding to it. Number 3, if they're not responding, finding out early, and then adding in other therapies or switching therapies. Some of the other therapies, when you're talking about things like adding some of the immunosuppressants, that's something we've done for quite a long time. When Tysabri came along, it was only released as monotherapy or single drug therapy, and so we didn't add any therapies into that. That's not to mean that you couldn't occasionally have a course of steroids for a short time, but for the most part, combination therapy in Tysabri is not allowed by the FDA, and I believe the European Union also has similar restrictions in that. There are other therapies that we probably should consider that are available, fairly severe or fairly aggressive disease requires aggressive therapies with immunosuppressants to try to shut down that immune response. So people are using things like Imuran, Celsep, methotrexate, cyclophosphamide. Sometimes people are using cyclophosphamide to knock out the immune system and the bone marrow in preparation for stem cell therapy. So all these things have been available and are being tried. It's just a matter of trying to find the route that's best for a given person. And certainly we know that what works for one person doesn't work for another. And you also have to be aware of the risks. As you go to more and more aggressive therapies, there's more and more risk involved, and so you have to be aware that you have to take a little more risk to be able to get the benefit when your disease is severe or particularly more active. Just mentioned briefly about Tysabri. It's the only infusible therapy that's been given as a preventative. It's given intravenously every 4 weeks traditionally, and it has been around for several years. The biggest issues have been related to really more the long-term risk of PML, which increases particularly after 18 to 24 months, especially if you're also on immunosuppressants in the past, and if you have presence of the JC virus in your system, which is the cause of PML. The vast majority of people that have the virus in their system do not go on to develop PML except if their immune system is suppressed for long enough periods of time. About 50% of us here and worldwide have positive JC virus. And so that's just a fact of life. It's just a virus that we've found. It's extremely rare to develop the PML infection though. And prior to Tysabri, immunosuppressants, and AIDS, I think we knew in my entire career one case of PML in several years of seeing patients in training as well as in practice. So it's just very, very rare, except when your immune system is suppressed. Okay. We know that there are a lot of different ways that the immune system is involved with MS and how the different drugs work. Some work on keeping the offending white blood cells in the lymph glands. Some keep them out of the nervous system. Some affect in different ways, such as the inflammatory responses in the T cells or the B cells. And it's amazing how we've learned so many different mechanisms of actions can have very similar effects on benefiting MS patients. And this is just showing some of the items both within and outside the nervous system. This is the blood vessel down here. And then you have the lymphocytes crossing over the blood-brain barrier into the brain, where they can produce damage if they're geared up to do so. Okay, so what we try to do is take someone with MS who has more of a pro-inflammatory balance and try to reverse that, because we know that inflammation in the wrong direction can be bad. We also know inflammation is good to some extent, but we just have to find ways to keep it in better balance, not only with MS, but also other autoimmune diseases. Okay, adherence is important in terms of trying to stick with therapy. I'll just mention a few things. Some of the reasons for people either not starting, or not continuing the different therapies are, number one, my MS wasn't severe enough. Well, we also saw from the study I showed you on benign MS that you really can't predict when someone's going to have benign MS. Sometimes the doctor doesn't recommend or advises against it. Unfortunately, you probably can't see it, and I can't see it that well, but you do need to be your own advocate, and you have to educate yourself and learn when it's best to consider starting some of these therapies and which ones are available. Some people are afraid of starting new therapies and the different severe effects, or even not so severe effects that can occur. We know that at least 90% of people will do well with a given therapy, and it's very few patients who have severe side effects that require them to stop. Cost is obviously a bigger issue for a lot of people. I noticed you didn't raise one hand. Okay, that's good. Inside joke. So the cost is an issue, and the pharmaceuticals, in all fairness, have realized that it's to their advantage to find programs to get patients to start on drugs. Because if you can start them on drugs, some of them are able to continue working or going back to work. They can actually get the drugs paid for at a later time. And so it's to their advantage to also try to get patients onto therapy and keep them on therapy. And that's all of our goals as well. There are other therapies that have been used, alternative and complementary therapies, and I think those are fine. But there's no evidence that those actually impact the disease course. So it's good to use combination therapy, alternative therapies, complementary therapies, along with the traditional anti-inflammatory therapies. Fear of needles, we now know that the needle phobia can be minimized by smaller needles, auto-injectors, even anesthetics if you needed, icing down the sites or heating up the sites if need be. And then if needles are really just too much of an issue, we now have either intravenous infusions, we have less frequent injections, to where a lot of the therapies that are once a week may go to twice a week, or once a week may go to once every other week. Those that are every day may go to 3 times a week before too long here. Those that are available sometimes once every month. There are therapies that are even available or becoming available that are once every 6 months or a year. So those infusions may become less of an issue over time. And now we also have, obviously, the oral drugs, which we can partake in and can be equally effective for many patients. It's up to you to talk to your physicians and decide what's best for you, and whether it's something worth considering switching from an injectable to an oral, or whatever that it takes to keep you on therapy. And the other thing that people used to say is they didn't know about the DMTs. Well, now you do. Okay. Some of the other things, these are just some of the items used for adherence. I'm going to move along here. And then future trends. Some of the alternatives, such as the experimental agents, can be used. And some of that can be done through experimental protocols, both here and other places around the state. There are a number of centers that will provide this free of charge. So it's nice to be able to participate in some of those programs. Be aware, though, that some of the programs, some of the research trials are placebo trials, which means that you sometimes in 50% you may get 50% placebo, 50% active drug. That's changing quite a bit. A lot of times now they're moving to a 1 in 4 placebo, where 3 doses of the active drug or 2 doses of the active drug and 1 separate drug along with the placebo is used. So that way you at least get a better chance of getting an active therapy. There is one that we've been doing recently where we look at an injectable therapy and an intravenous therapy, and both patients get an active drug, except one of those may be placebo, so they may get an injectable active drug and an intravenous placebo, or vice versa, but they're always getting an active drug. Some of the future oral agents, laquinimod is a drug that's being studied, has not been released as yet, seems to have significant effects for disability. Aubagio is looking very promising for CIS patients, which is an earlier phase of patients. Something called anti-lingo is helpful in helping the remyelinating process. Boy, the handwriting's getting really small, my eyesight's getting really bad. Okay, there's something called alemtuzumab. Okay, we're going to wrap it up here. Alemtuzumab. Oh, you're done? Oh. Oh. Oh, good. I won't need that much. Okay, so we got alemtuzumab, which was recently declined by the FDA to be released to the public, so that may require additional study before it's released. That was a once-a-year therapy, and the good news is it was only a once-a-year therapy. The bad news is once you give it, you can't take it back. And so there had to be very careful monitoring of the drug afterwards, and there were some relatively minor complications, and it is still considered an effective therapy for many patients, but that's going to be on delay here. Certain injectables such as daclizumab every 2 weeks, Copaxone scheduled to go to 3 times a week this year, something called pegylated interferon, which is Avonex prolonged effect, which may be once every 2 weeks. Okay. Stem cells have gotten a lot of press, and there's an excellent website on the FDA website that's something worth looking into, because it updates stem cells. It shows how they no longer have to use fetal stem cells. They've found ways around it. They can actually turn on stem cells after they've already been growing in the body. I mean, it's just amazing what kinds of things are being done with stem cell research, but it's still not ready for prime time, and it's not a traditional or platform therapy as yet. Bone marrow transplantations, implantations, and so forth. So there are a number of promising things out there. You just have to keep abreast of the research and see where it's going. And hopefully when I get back here next year for the Boston meeting, we can talk some more about it. All right, so some of the main things that are common sense, but people tend not to do very well, are exercising regularly and within your own physical abilities, and we certainly will hear about that shortly. Resting your mind and your body periodically through the day. I tell people to drink cool fluids, also jump into showers or pools. Try not to do that tonight, though. Use common sense with eating, less fat, more fruits and vegetables. Use alcohol and other substances in moderation. Eliminate or reduce tobacco smoking. Getting good quality of sleep as well as quantity of sleep. Stuart gets great quality of sleep within 4 hours. I'm very proud of him, and I wish he would teach me the trick. So. Okay, find ways to lessen stress and learn to better deal with it. Keep your family and friends involved. Try to do something every day that's fun and to laugh every day. And then, of course, if you don't already have kids or grandkids, you can borrow them, or like they do in Japan, they rent them. But this is what I do for my fun days. This is my only grandchild, granddaughter, who's now 14 months, but that was her her first birthday. And anybody have experience with young kids with cakes? Okay, good, so you know I don't have to tell you. But it was a messy time. The dogs loved it, though. Thank you very much.
Thank you.
So we'll now open up to Q&A.
You mentioned something about vitamin D may play a role. Is that something I should be looking for in my daughter? I know this is hereditary, and since I'm newly diagnosed, I want to take every precaution I can for her. Should I be watching her vitamin D intake now?
I think vitamin D is going to turn out to be one of the big breakthroughs, not just with MS, but in general, because if you start watching vitamin D levels in patients, it's amazing how people are either low normal or very low. And MS patients tend to be down at that lower end of the range. There have been a number of studies, and this is not something that's a cure, it's not something that's essential to jump right on it or you're going to fail. This is just an observation that came out of the VA trials a few years back that showed that those MS patients who had vitamin D levels in the upper 2 quartiles from about 65 to 100 seemed to do better in general, had less disability than those patients who are in the lower quartiles. There have been additional studies that have shown that giving vitamin D supplements, not even very large amounts, usually about 2,000 units, can lower the risk of people developing clinically definite MS, at least delay the effects when they had clinically isolated syndromes. Stuart knows I sometimes fall over things here. So I think we know that those patients that we follow, if you give them vitamin D supplements, that they have lower risk of exacerbations, lower risk of going on to developing clinically definite MS if they didn't already, fewer attacks, less disability. So there seem to be significant benefits. How the exact mechanism is not completely understood, but it seems to be related to that interaction with the immune system. So supplementing is extremely important. We just don't know any specific level to recommend. We know that the higher levels seem to be better. People worry about being toxic, but the actual incidence of toxicity from vitamin D is extremely rare. I mean, we've had patients who are well over 100, which is the upper limits of normal, and done very well. We don't necessarily keep them there, but if they're just slightly above the 100 range, I don't get too concerned about it any longer. If you watch calcium levels, you can also watch urine calcium and other things, but that isn't really necessary because the incidence of difficulties is really few and far between. So it turns out to be an easy treatment. It's very easy to monitor. You measure something called the 25-hydroxy vitamin D level, which is your level of storage in the body, and it's what's converted into storage after it's converted from the skin. You all hear about sunlight being exposed to sunlight converts it so it can be used in a usable form throughout the body and then stored. The problem is I see lots of people out in the sun all the time. I see people who, really have pretty dark complexions, and their vitamin D levels can be extremely low. And even the African American population can be extremely low, and no one really understands why. I mean, I think part of it is diet, part of it is the sun exposure, part of it is that we've been indoctrinated about using sunscreen to prevent skin cancer, so we don't get as much of that vitamin D. But supplementing with vitamin D can be extremely helpful. I usually start people off with 2,000 units. Very quickly, you can go to 5,000 unit capsules a day, and it's usually very well tolerated. Now, it is a fat-soluble vitamin, so you take it with a meal, usually dinner. Some people have to break it up because they can't tolerate it due to gastrointestinal upset, but for the most part, it's been very well tolerated. Now, in terms of the genetics have been played up a lot, but I don't think if you actually look at the genetic research, the ability to transfer MS to your future children is very, very low. So when you start with a population that you would think have close to 100% identical genetic makeup, which are identical twins, and you look at one twin with MS, what's the chance that the second twin will develop MS through their lifetime? It's only about 37%. So it's obviously that nurture-nature, only 37% of it appears to be genetic, and so 63% is really not affected in that way. if you look at the next highest risk, which is mother to daughter, it's really only in about the risk of about 12-15%. And then it keeps dropping from there, mother to son, then father to daughter, father to son. So we know it's higher risk in women because, as most autoimmune diseases are, it tends to predominate in women. But the genetic factor doesn't seem to be nearly as prominent as we worry about. Also, when they started looking for genes that seem to play a role in MS, they found that it's very rare to actually come up with these different kinds of genetic patterns. And so it makes it tricky because they're finding dozens of different patterns genetically, but only a fraction of the population has each individual component. So, and then when they think about how genetics may play a role, it may be that it requires hundreds of genes to be involved in the immune system, which would make a lot of sense if you want to try to survive in our violent bacterial-driven world. But if you go ahead and look at that, I mean, everybody's so different genetically, and it's probably combinations of genes, dozens of genes that play a role. But everybody's so different genetically, and that's why MS looks so different from person to person. We try to make some sense out of patterns and so forth, but not always easy. Next question. All right, let's try on the right side of the room. My right. Questions? I can't see. Okay.
Yeah, hello? You say they got something coming out that's going to be able to regenerate the mylar on the nerve wrap?
Yes, there's a number of medications that they're looking at to try to help build the myelin sheath and try to help us regrow. Early in the disease with MS, we have a remarkable ability to remyelinate. That's why the vast majority of patients, unless they have very devastating forms, can remyelinate on their own even when they're not treated. The vast majority of exacerbations early on get better, and that can get better within a few days to a few weeks. And so that's remyelination occurring naturally. That's our own body's ability to be able to regrow that myelin. So what we're doing is developing drugs to enhance that effect, particularly as the disease gets further along in the disease, gets further along in the course of the illness when our immune system doesn't regenerate as well. And so as we get older and the nerves don't regenerate quite as well, this new drug hopefully will then stimulate growth and remyelination for us and take over that function. So that's what I think a lot of the research is, to try to take advantage of that effect.
Yeah, even with the white blood cells attacking, that sounds like a breakthrough right there.
And it is. And I think a quote-unquote cure for MS, at least in the near term, in this next 5 years or so, will look like a combination of therapy, one drug to give for the actual anti-inflammatory effect like we're doing now, and another drug for the remyelination to enhance the effectiveness of our regrowth and our ability to overcome whatever attacks have occurred. And by using that, I think you get it from both, you get the advantages from both sides of the equation and be able to get better results.
And the secondary question I had was, I see the conference you went to see. A lot of them are probably over there in them foreign countries. Is the reason for that is because they let you do a lot of things that America won't let you do, and so you're able to see some different therapies and
well,
maybe
I don't think it's so much
express-
that. I think what happened is Ectrums started in Europe, Actrum started in America, Lactrum started in Latin America, and now you're seeing a lot more cooperations. Whenever the studies are done now, especially the larger studies, they're done globally. So there are centers from all over the world now that are participating in these studies. And so it used to be where the Europeans didn't have the restrictions that the FDA had, and so they could get things rushed through pretty quickly. Of course, we know that sometimes rushing things isn't always ideal. But we're seeing a lot more international cooperation, a lot more cooperation with regard to studies. And so, it's not at all unusual to see some of these more recent studies to be done in the United States, most commonly Canada, Latin America, Europe, Eastern European bloc, previously European bloc countries, Asia. And so this is exploding all over the world. I mean, they're having to go to find patients now because everybody in the United States and North America pretty much are on drug. And so they're finding people that are newly diagnosed in these other countries, and they have the opportunity to bring them into the fold, so to speak. So I think it's really just this globalization. I mean, there's better communication, there's the internet. We're now able to cooperate on these studies and research, and as soon as a discovery is made in one part of the world, it's instantly known somewhere else. I mean, this is all unprecedented. So it's very exciting to see that kind of trend in research throughout the world. And that's why, of course, it's not very difficult to force yourself to get on a plane and go to places like Copenhagen or other parts of Scandinavia or France or England, where a lot of them are going to be. So I think the idea is to being able to participate in this kind of globalization is tremendous.
So hard on you, I can tell.
Yeah, it really was tough. That's why I'm sick now.
You refused a lot, didn't you? Kicking and scratching.
That's right. That's right. Yeah, get me on that plane. Okay, another question from this side.
Who's got questions? Come on, you guys got to have questions.
Questions?
Did the doctor not say anything that you
Here we go. We got one right here.
How effective is your diet with MS?
She did.
I haven't.
So the
your
question is,
diet-
how
your-
effective is the diet for MS?
Yes.
That's been an area of debate for a long time. There used to be other diets that people said could cure MS, and we're finding that they're helpful, but there's nothing that cures MS at this point, diet or otherwise. So the idea is to try to not eat a bad diet, because we know bad diets can hurt you in other ways, and the more you impact your cardiovascular system, leading to strokes or heart attacks, then it doesn't matter what your MS is doing, it's going to get worse based on these other factors. If you eat healthier in general, that's a big plus. I put up there a couple of diets that I believe in, because not so much because I tell everybody they have to go out and start them, but just because they've been done by people with scientific backgrounds, and they seem to have some physiologic sense. One was by Dr. Sears, who does the zone diet, which seems to make a lot of sense. There's Terry Walls, who has a variant of the hunter-gatherer diet. So all this has some basis, in fact, in terms of eating lots of greens, balancing the amount of protein and fat, minimizing the wrong types of fat, trying to keep things in better balance. And so all those things make sense for me. I encourage patients to at least look at them, but whether you go on them or not is not going to make the difference between whether you're going to walk in or not. Now, for Terry Walls, it had a dramatic effect. She stuck to this diet, and she actually improved despite all the failures that she had with other medications. Now, she understands that that's one person, and so what she's done is she's tried to develop more of a database where people can share their experiences. She wants to do more studies, actually present it to the dietary societies to have some more proof that these things do work and can work, and what does it take what are the key ingredients of that diet that will enable us to recommend it to patients. So I think she's gone about it in a way that's pretty unique, and I was very impressed with as a fellow physician. So she was a physician, I don't know what specialty, but she had deteriorated to the point where she was completely wheelchair bound, and she ended up going on the diet and gradually improved, and now she's up walking and exercising and other things. So. But again, it's not going to work for everybody. Everybody's makeup is different, but I think it's something to at least look at and consider. Certainly the kinds of diets that we're eating in the United States and elsewhere could be improved upon. That's a whole other discussion.
Anybody else?
we'll get you in. We'll come over here next. Yes.
Does spinal stenosis have any effect on MS?
The question is spinal stenosis. Everybody know what spinal stenosis is? Anybody not know what spinal stenosis is? Anybody have spinal stenosis?
Yeah, right here.
Okay. Spinal stenosis basically is a narrowing of the spinal canal, and it can occur at any point along the spinal axis from the neck all the way down to the lumbosacral spine area. It usually is due to degenerative changes in the discs and ligaments surrounding the spine, so it slowly squeezes in on the spine so that you get more and more narrowing. And then what happens, the nerves start to get squeezed, and when the nerves are squeezed, then you start to develop more symptoms, anything from pain to weakness, numbness, and so forth. Typically, it's more with activity in the lumbar region, but it can be pretty devastating for some people. There's no direct relationship between that and MS. It's two completely separate diseases. However, I'll tell you a story. I had a patient who had MS for 30 years. She came in complaining of new onset of leg weakness. She had never had leg weakness before, or if she had, it was minor. And I said, well, you know, it's unusual for MS to have attacks so late in the course. Let's at least look at your spine, make sure we're dealing with MS versus something else. And she had spinal stenosis. She had very severe narrowing of the spinal cord in the thoracic area, which is the mid part. And it was squeezing the nerves and causing and mimicking the same symptoms that she could have had from MS. Now, the problem is, if you already have a little bit of weakness and the weakness is getting slowly worse, you don't know if that's because of the MS progression or if it's some other problem like spinal stenosis. So if you have someone who's getting worse, you have to at least think about and talk to your physician about the possibility that there may be other diseases combined with the MS that are causing the weakness and combining spinal stenosis and MS. So that's how I relate the two. I think it's just being aware that there are things other than MS that are creating symptoms. Let's come back over here.
Yeah.
Oh, one more.
Back to nature nurture. I'm an identical twin. I don't have MS. My clone over here has MS, okay? But so does my son, Jeffrey.
Okay.
So how could that be explained?
It's just bad luck. I mean, basically, when your genetics are passed along, certain genes are passed along, and so you may still have the genes for MS, but maybe not sufficient. But then you take that together with his father's genes, and maybe some of his genes were in the same risk category for MS, and you put them two together, and it was enough to manifest MS.
So wouldn't that validate the nature aspect of it?
Oh, certainly. Certainly. So I think we don't know whether it takes a certain combination of genes, certain number of genes that are predisposing to MS. That's the problem. We haven't worked out all those details as yet. You're welcome.
Good question.
Over here.
Hello. When I first went to the doctor, I'm back here in the back. I'm an African American female, of course, female. The first thing my doctor asked me was, where was I born? And I told him in Maryland. And first thing he said was, it figures. And I didn't understand that, but he said that a majority of MS patients born in the northern hemisphere, whatever you call it, are diagnosed with MS. What is your output on that?
Okay, there's a lot of debate about this. Part of it is your genetic makeup. Part of it is where the genetics migration occurred. So based on fairly important scientific research, the theories are that man and women began in African and Asian areas, then migrated up into Northern European, and then over to the Americas and so forth. And so the genetic code changes, and so you have intermarriage, you have time, centuries of change in the genetic code. So that's one aspect. Mixed in with that is this northern latitude versus southern latitude. Thank you. And so when they've looked at populations of MS patients, there seems to be a higher chance of developing MS if you lived in northern latitudes north of the equator and more southern latitudes south of the equator, so closer to the poles. And so it appears that there's some mechanism that's playing a role there. Now the question is that genetic migration? Is it the fact that colder environments mean less exposure to the sun and lower vitamin D levels? Is it because you're indoors more often, exposed to viruses and other people, particularly in the early age groups? Now that seems to be a predominating factor if you stayed in the northern latitudes before age 15. There's not a precise cutoff, but age 15 statistically seems to make a difference. So less than 15, if you migrated under 15, it's a lower incidence. If you stayed up past age 15 before you moved south, then your incidence would be higher. So there's something about being in northern latitudes. So is that, as I mentioned, the different risk factors for vitamin D? Is it virus exposure? Is it genetic? Or is it more likely to be a combination of different factors? So there's probably lots and lots of factors. I once gave a lecture at one of the Melbourne meetings. It was a support group. And we talked about all these different risk factors. And I went down the list, and I had everybody put down a log of 20 items, and which one was, which one of those items did you fall into? Were you a woman? Were you Caucasian race? Were you northern latitude? Were you northern European origins? So all those are higher risk factors. And then we went around the room, okay, how many risk factors? Very few people had more than 3 or 4 risk factors, but very few people had less than that. So I mean, it's pretty amazing. It doesn't seem to be any one thing, but it's a whole host of factors that seem to work in concert to develop this kind of pattern. There's a question down over here.
Stu already answered
Oh,
her question.
okay.
Anybody else has a question over here? No? Over here. Oh.
Question from the back. Stem cells. You haven't spoken about that. So what's going on these days with stem cell research?
Au contraire, you obviously didn't sit through mine. The stem cells are really, I think, at this point, very early in the infancy. Now, they're not ready for prime time. They're not FDA or European approved. It's not something that you can really depend on as being a cure or being a primary therapy at this point. Part of it is because of risk. Part of it is because it's really only being used for relapsing forms of MS. We think that it may play a role later on when we're trying to remyelinate. So not only putting in stem cells, but putting in what are called oligodendrocytes. So the oligos are what generate the myelin, and we want to take a cell that's a little advanced to that, so it differentiates from stem cells to the myelin, and then eventually to the myelin. So you want to get those earlier cells into the body and be able to start generating myelin. If you go to stem cells, you have to kind of depend on luck as to whether they're going to differentiate towards the nerve cell side or towards the myelin side. If you put in the promyelinating cells, then you've already designated those cells that will go towards myelin automatically. So, and then with the new stem cell research and you can read this online through the FDA.gov, it's really amazing what they can do with manipulating these cells nowadays. But it's still not in big enough numbers or effective enough to really impact the disease yet. So I think it's very interesting, it's very exciting, but it's not quite there.
So thank you for that question. Another question that came up recently was that people wanted to know about why the FDA has now approved research on venoplasty. The CCSVI has now been approved in the U.S.
Okay.
What can you tell us about that?
I don't know much about the FDA's impetus behind that. All I can tell you is that the research coming out of European Union, in fact, out of Italy itself, where the procedure originated, has been really pretty negative in the sense that they've looked at patients and tried to figure out which patients, based on their venous ultrasound, would fit a pattern of MS or not. And there was no consistency in what they were finding. Now, this is assuming that those patients, those physicians that were looking at the ultrasounds weren't biased by what the patient looked like. And what they did is they did double-blind studies where they took the readers separate from the physicians that were treating the patients, and they couldn't find a good enough correlation to recommend it. And so a lot of the European Union has pretty much abandoned CCSVI, except just Dr. Zamboni in Italy. So it's been interesting the way that's come full circle. Going to these meetings, I don't feel anybody is very excited about CCSVI at this point. And I don't see anybody recommending that.
So for those that don't know what CCSVI is, it's something that's been in the news for a while. CCSVI stands for chronic cerebral spinal venous insufficiency.
Okay.
Okay, and it's a topic that a lot of Canadians bring up all the time because they are doing extensive research on this in Canada. So I know somebody over here had a question.
You know, and I think it's one of those things where the studies that have been done haven't shown drastic changes. Some of the patients of mine that have gone and had the procedure haven't really found any benefit or had only temporary benefit. And some of them have to have the study repeated. It's basically an angioplasty of the venous system instead of the arterial. Some people have had to have it repeated. Some people have had complications. There have been deaths reported. So it's not something I feel we have enough benefit to warrant the risk involved.
Okay, sir.
Well, you may have touched upon this with the stem cell answer you just gave us, but when you talked about the myelin regeneration, it's very interesting because that's what MS patients who have some disability are looking for and hope for, that there is a way to regenerate the nerves, to repair the myelin, to get use back of what areas they're, disabled. And my wife has disability on her left side. It seems to be getting worse as the years go on, and we're hopeful that something would come out that could be regenerated that would bring her back to being less disabled. Is that possible?
There's actually two components to the problem with regeneration and with damage to the nervous system. You've got the myelin component, but then you've also got the nerve filament component. And so the way this progresses is initially there's damage to the myelin. It gets repaired by our own bodies initially. Then you put people onto medication, which enhances that remyelination, prevents the inflammation. But if there's enough damage to the myelin, eventually you start to lose the nerve cells inside of those filaments. Once you lose those filaments, then you lose the nerve cells, and then you actually lose a lot of function if it's allowed to continue over long periods of time. So you've got those different aspects. The idea is to try to protect the nervous systems. That means protecting the myelin and protecting the nerve cell themselves. Regrowing those is another issue too, because if you've already lost too many nerve cells, then you don't have and lost too much myelin and lost too much of those oligodendrocytes and astrocytes. So if you're having these black holes develop, you don't have the architecture and the structure to be able to support new cells running through there. So you have to catch it early enough so you can still maintain the structure and people can still make connections from one point to another. So a lot of it is trying to protect the nervous system early on through the traditional therapies and through some of these newer therapies. So I think by catching the disease early, by treating with these newer therapies, by doing everything you can to protect your nerve cells by not drinking excessive alcohol, not smoking too much, or not smoking, period. All those things will help protect the nervous system in the long run. So I think a lot of it is how do we keep the nervous system at an optimal level structurally and functionally. And these are issues we're wrestling with only very recently. So these are things we're all starting to pay attention to and trying to find ways to slow the process down.
And just one other question, where the lesions are located, we're understanding that makes a big difference in disability. For example, lesions located in the back down the spinal cord tend to be more disability, creating disability more so than lesions in parts of the brain. Is that your
I
understanding?
think the easiest way to visualize that is if you think of the brain as this big, vast organ, and it's spread out over many billions of nerve cells, and there's lots of convolution, which allows more nerve cells to develop throughout a lifetime. And then what's happening is all the cells are congregating down in the brain stem, cerebellum, and into the spinal cord, and it's become very compact. And when it does that, when you have a lesion in those other areas, there's less redundancy and it's less forgiving. So once you get permanent damage in those areas, it's harder to recover. And that's why people with more severe disability tend to have more severe disease in their spinal cords. And so when I evaluate patients for the first time, I want to know not just what's going on in the brain, because I may be able to make the diagnosis just on a brain scan, but I also want to know what their spine looks like. And if their brain looks relatively mild, but their spine looks pretty active, I'm going to treat that patient more aggressively, because I think we have a lot to lose sooner if we don't. And so I think you're touching on a very important point, and that is that you do have to look at the location of the lesions. You do have to look at how fast the lesions are developing over the time, and at what point we're catching the disease. In other words, someone may come in with their first symptom, and you look at the MRIs and it look like they've had it for 20 years. And so that person probably needs to be treated a little differently and more aggressively than someone who comes in with a few attacks, but their MRIs, both brain and spine, look relatively mild. And so that's where the art of medicine, trying to convince patients that you have a higher risk than the next person. Let's get you on medicines that are more aggressive.
Okay, any other questions? We have time for just one more, please. I guess you're the one more. You're the only one raising your hand.
How long have you known about the different lesions of the brain and how they affect the disease? Because this is kind of something new that I'm hearing about. And so I'm wondering, did my first MRI show different types of lesions?
So what is the question you're asking?
How long has the different types of lesions been known about? Is it been...
Well, ever since MRI has been available, which has been, it's been used for MS studies since the 1990s, but we've known that MRI opens amazing windows into the brain since the 80s when it first was evolved. So I think it's, when you look at all that time, not everyone has had MRIs done on a regular basis. It's only been since about 2000, 2005 that we started to do MRIs on a more regular basis and to look at other parts of the nervous system. So we're learning just like you are learning about not only your individual disease, but how patients are responding. And so this is something that's starting to come together more and more as we go along. So it's unfortunate. I mean, it's very hard to differentiate one person versus another in terms of, aging their disease process, because their MRIs are the only way we have, and not everyone has had MRIs, and not everyone has shown lesions like you do on others. So it's a complicated process. One more.
Last question.
To piggyback on that, how often would you recommend that someone does have MRIs done?
Okay, well, I'll use the attorney answer, which is it depends, but my own personal experience depends on the person and depends on their symptoms. So if someone comes in with their first attack, I may do an MRI of the brain and of the spine, and then since I don't know how active it is, if they don't meet criteria right away, I might do another one in 6 months. And then depending on how rapidly things are changing, I might do it pretty often that first couple of years. There are people who come to me who have already had the diagnosis made, have already had a number of lesions, and now are pretty stable. And I'll look at their past and their current MRIs and say, okay, you're in a very stable situation. You haven't had any new lesions since you started drug A. Let's go to 1 more year from now. If it looks good, we'll go to every 2 years or every 3 years. So some people are stable enough that you don't have to do it. There's some people who are just very, very aggressive, have very aggressive disease, and I'm doing MRIs every 3 and 6 months sometimes. So it can be problematic. But everybody's a little bit different, so I tailor it to the person and their insurance company.
Okay, so that's going to wrap us up for the first part of this program. Dr. Gold, thank you very much. I know I really strained you tonight from, all the hoopla you went through last night. I mean, next time we'll have to put FSU and Auburn on hold for you. Okay, so we're going to take a 5-minute break. Does anybody need the restroom? Get up, use the restroom, come on back. You're going to have dessert coming out in a few minutes. We're going to clear this area so that way Jeff could get set up out here, and we're going to need to know who wants to volunteer. Who is going to volunteer? But remember, though, if you want to volunteer, we're going to be video recording this. So if you want to volunteer, do you want the world to see you doing these things? Come out here and have fun. We just need you to sign something, okay? We'd really like you to come out here. Thank you. We'll be right back. Everybody ready? We're going to begin again. Anybody here that's not here? Oops, I said that wrong, didn't I? I must have said that wrong. All right, it's all right. I'm allowed to say things incorrectly. Anyway, Jeff Segal also has multiple sclerosis. For people with MS, there's a line at the bathroom. I know, it's a selfie. It's a real selfie, I got it. So anyway, the line in the bathroom, they're just going to have to miss the beginning. All right, so Jeff has multiple sclerosis. Can you imagine that? Yeah, he really does, though. And so Jeff decided to do something when he felt like he wasn't doing enough with life, and Jeff got involved with doing all this personal training. And so Jeff gets around the country doing this for certain pharmaceutical companies, and MS Views and News uses him. We use him a lot to do programs in the state of Florida. And hopefully, we'll be able to get him out of the state as well as we travel outside the state. But meanwhile, though, we want to present Jeff Segal here tonight to do what is going to greatly benefit many of you. Okay? Thank you.
How's everybody doing? You guys happy? You got your food? It looks like most of you ate it too. Even better. Thank you, Stu. Thank you, Dr. Gold. Thank you, all of you, for coming out, because these programs don't work without you guys attending them. And from what Stuart said, yes, I do have MS. I was going to surprise you with that, but he blew it for me. So surprise. That happened about 15 years ago. I was finishing up college at FSU. I could do that right now, so national champs is great. Great for losing a lot of sleep, too. But I went through what most of you went through to a certain degree. I mean, there was a time that I couldn't stand. I was in a wheelchair for a good amount of time. I couldn't see very, very small amounts at a time, and not with both eyes at the same time. And I wasn't able to really talk. That would have killed this lecture. So that's why I'm here, because now I can talk, and now I won't shut up. I've been told I'm a man of a few thousand words, so bear with me. What happened was, prior to I studied exercise science in college, and prior to that, I was an athlete. Everybody in here is an athlete of some sort. I mean, I call playing around as children, that's the beginning of athletics. And when you're a child, it's fun. So is anybody in here not exercise? You don't exercise? Is there anybody in here who's never exercised? Is there anybody in here who's never had fun? Okay, so I'm in the right room here. What I try to do is I try to introduce types of exercises that are right for you. And everybody has, their pros and cons of what they can and can't do. But if you can find something that works for you, you're going to do a little bit better, and you may enjoy it. And you'll have a smile on your face, because exercise doesn't have to go along with words like work. I mean, it is hard work. Anything that you're going to do a little bit better at is going to take hard work. But there's one thing that only you can control, and I want you to think about this. Does anybody know what that is? The one thing that only you can control is your effort. And that's big, because without an effort, you get no results. And whether it be exercise, whether it be work, no matter what it is. But one thing that we do live with are incentives, right? If there's not an incentive, you may not be as likely to do something. So what I'm going to do is I'm going to ask everybody in the room, if you'll participate, which is not going to be anything difficult. The only rule I have is that you give 100%. Fair? So I want everybody to raise your hands as high as you can possibly raise them. Okay. Now raise your hand this much higher. Okay, you can put them down. Was I not clear when I said to give 100% at the beginning? Because this much higher is that much more. It's not 110%. And if you look at everything that you do day in and day out as, am I giving my all? Am I giving enough? Am I giving an effort? And if you're not, then you should. And if it's something that you're unable to do, then you do something different. Goals are something that we should all have. Anybody here not have goals? Anybody here's goals have been the same thing for years? If your goals were the same thing as they were 10 years ago, you need new goals. It's simple. And if for some chance your goals, the things that you want to get done, are not feasible, or you can't do them because of something such as MS, it doesn't mean you change your goals. It means you change your direction. You don't, if you want to get to the other side of that wall, how many times are you going to walk into it before you realize you're going to go through the door around the corner? So sometimes it may take a little bit longer, but you do what you can and you give effort. And when it comes to exercise, you have potential. Everybody's got potential. That's another thing that you own. Nobody else can own your potential. And if you know what your potential is and you reach it, then hey, you've hit that goal. That's what the goal in life is, to get to your potential. Now, back to what I said about raising your hands and raising it a little bit higher. What would have gotten you to raise your hands even higher? What if I said I got a $10,000 check in my pocket, which I don't, for the first person that can raise their hand 2 feet higher than you did to start? What would you do? Exactly. Yeah, you'd find a way. You'd find a way to get that $10,000, and for $1 million, there'd be people fighting for the hanging from the ceiling over here. And that's what it's all about. And if it could be fun while you're doing all that stuff, it's even better. And then people will see you smiling. And they won't see you as that person that's picking most of your day apart, thinking about the things that you can't do, and utilizing the things that you can do to achieve your goals. It seems pretty simple, doesn't it? It's a lot easier when you stop and drop the things that you can't do and put them aside and focus on what you can do. Now, anyone here know how many hours there are in a week? 168. Okay? What do you do with 168 hours? If you get 8 hours of sleep every night, tell me your secret. But if you do that, then you're left with 112 hours. I'm not sure if my math is right, but let's just say 112 hours. Okay, so you got 112 hours. Now, what are you going to do with that time? How much of that time are you going to be thinking about negative things and things that you can't do, and how many of those hours are you going to actually be doing something that's going to help you? And when it comes to exercise, I'll tell you, everybody can do it some way. And the results are similar for people with MS or who don't have MS, because it goes back to the effort. So if I were to hold something in my arm, and if I was able to do this all the time, this arm's going to get stronger. And if I increase the weight, it's going to still get stronger and stronger. And that's what your body does. It responds to the imposed demands that it's given. That's why we get stronger and bigger, and we get more muscle fiber, and we're able to use it more. Now when it comes to MS, your nerves get in the way of that. So you got to figure out where you are and what you're able to do. I've got a whole bunch of exercise equipment back here that I'm hoping there's something for everybody that you can see that would fit what you like. How many of you don't play anymore? I mean, it's kind of funny to adults to ask each other, do you play? You know, I could get in trouble if I go too far into that. But what do you consider playing? And when did you stop playing? And when was the time that you woke up one morning and looked at yourself in the mirror and said, I can't play anymore, I'm too old? It doesn't happen, right? It doesn't happen, but what happens is things get in the way of what we are used to doing and routines and all that stuff. So with those 112 hours that you have, you can find a couple hours for the whole week. Let's just say you put 2 hours into exercise. It sounds a lot, 2 hours, but you know, 2 hours can be 30 minutes a day. It could be 10 minutes at a time several times, or it could be 2 hours a day. I mean, that's not unheard of. And there is over-exercising too. But what exercise fits you best? And it goes down to what are you willing to do? Because there's a lot of stuff out there. There's what you can do, there's what you want to do, there's what you should do, but none of that matters if you're not willing to do it. So you find something that you're willing to do. Anybody in here like sports, football, basketball, that stuff? When was the last time you played it? When was the last time you shot a basket? Or whatever it might be that you like doing. I carry 2 basketballs in my car. They're the kids' balls. I use it more than them because I'll be driving down the road in between clients and I'll see a basketball court, I'll stop, I'll take a couple shots, or maybe a lot of shots because I won't stop until I make it. You know, the last one you got to make, that's how I feel. And then if you make it and you start to walk off and you say, I can do one more, and you miss it. And so you're stuck out there for a lot longer. But it's good because it's fun. And the other thing is seeing yourself happy is very important. How many of you smile at yourself in the mirror, ever? Look at yourself and smile. If you do that first thing in the morning, I'll tell you a secret. If you get up in the morning, what's the first thing you do when you wake up?
You don't really want to know.
Yeah, I think I do. Use the bathroom, right? Right? That's pretty much what we do. But usually there's a mirror in between where you are and the bathroom. So if you were to stop in front of the mirror on the way and do this, it's really not like that because it looks more like this. But if you do that, you'll stop, you'll look back, and you'll probably laugh, and then you'll go about your day. And at the end of the day, no matter how bad your day was, you can say, well, at least I smiled today. You know? And that's important because that will change how you see things. And when people see you smiling, they will think, and if you're vocal about having MS, oh wow, they have MS and they can smile, right? You know, we could also breathe and we can, you know, we can cry, we can laugh, we can do all the things that everybody else does. So when it comes to these different types of exercise, anybody have any questions about exercise or why they don't exercise or want to bring that up so I can go in that direction? Because this is for you guys. I can sit here and I can tell you the recommendations. I can tell you how much weight you should put on a bar if you're, you know, depending on your strength or how many reps you should do. But what is it that you guys want from this? Or do you just want me to put on a show of exercise? Okay, well, I can't do it alone, so I'm going to need someone to come up and assist. But anybody have any questions? You guys know everything about exercise. You guys are in the right path. If you don't exercise, you know how you're going to start, and it's going to be tomorrow, right? Come on, what's today's date, the 7th? Yeah. Does it take 8 days, 7 days to lose your resolutions?
I had a different one.
Yeah?
Stop smoking.
Yes.
I would say, how do you stay motivated
To exercise? Well, I'll tell you, what I do is, I'll tell you what I do when I'm working with my clients, who I'd say over 90% of them at the current time have MS, is I find out what they can do, and then I find out how to get them to do it a little bit better, and a little bit better until they can see a difference. And when you can see a difference, that's your motivation, or when you can feel a difference. You know, how many people in here have fatigue?
Everybody.
How many people have fatigue because of MS? How do you know?
You would have fatigue. It wasn't there in the forced situation.
Right, so what I do is I try to figure out why people have fatigue, including myself, because I do struggle with fatigue at times. But I think about yesterday, this morning, what did I eat for dinner? What did I eat for breakfast? You know, did I eat dinner? Did I have breakfast? Am I going through anything that's difficult in life right now? Am I having problems with a relationship? Has somebody close to me had an illness, a breakup? All these different things add to fatigue.
How do you find out what the clients can do? I mean, you put them through a trial or something?
Yeah, I give them an assessment, and I measure things. I measure things such as, can you stand up out of a chair? If you can stand up out of a chair, can you do it twice? Can you do it 5 times? How high is your heart rate after doing it X amount of times? So I'm learning. I learn by watching and giving them a series of things that they can do. Can they stand on one leg? Can they stand on no? No, I'm not going to try that. But can they sit on a stability ball? This is a stability ball. Can they sit on this? How's their balance on this? Can they sit on this with one leg in the air? With 2? That's kind of tough also. But I can see what they're able to do. And then I you can, but you have to do it. Thinking about it and wondering about it is what usually happens. And if I asked all of you why you don't exercise, just think to yourself why you don't exercise. And then I'm going to ask the question that I always ask is, how many of you that were paying attention to me when I said, why don't you exercise, and think about it, thought back to when you did exercise or when you were in the best shape of your life? Any of you think about that and say, well, I used to be able to do this and now I can't? Because that'll get in the way 9 out of 10 times. Because what you're doing is you're figuring out when you were the very best you ever were in your whole life. And that's what comes to mind. You know, have you ever played basketball? Yeah, and you think, oh wow, I played in a game, I was on a team, I scored 10 points one time, that was the most I ever scored. And no, but you got to think about how much work did it take to get to that point. You know, that's what it's all about. Because weight loss is, you know, how many of you want to lose weight? What's easier to do, lose weight or gain weight? It's easier to gain weight, right? Well, it takes a lot quicker to lose it than it is to gain it, because if you think about how much you weigh today and how much you weighed when you were 18, okay? How long did it take for you to get from 18 till today, to today? A long time, right? And let's just say 50 pounds ago. 50 pounds ago, it took 30 years to gain 50 pounds. Well, I'll shed that off of you in a year and a half, no problem. You know, and a lot of it doesn't just come from exercise, it comes from, well, spoon curls and fork curls, those type of things. But, you know, if you're going to exercise, say, 3 hours a week, is that enough? It might be enough. It's a good start. But what do you do during the time that you're not exercising? Because nobody goes to the gym and gains weight, unless you're going to the gym with a lunchbox, you know? So you go to the gym, you move, you do stuff, you get stronger, you gain stamina, and one of the things with MS that's difficult is your stamina, you know, whether it be from fatigue or whether it be from conduction failure, because some people that can lift a weight 10 times, say a 10-pound weight 10 times with this arm, may only be able to do it 6 or 7 times with this arm. Not because they're not strong enough, because the signal just doesn't make it there. So what you want to do is you want to maximize the reps that you're able to do. And believe me, it works. You know, you'll get stronger and you'll gain stamina. So I'm going to show you some different things like medicine balls. Anybody ever worked with the medicine ball? Yep, you've done it. You want to come up here? No, do you want to come up? No? Okay. I'll do it for you. Medicine ball, you can do all kinds of stuff. This is a 5-pound medicine ball. You can do just about anything you can do with a regular traditional weight with this. But one thing that I like doing is slamming it at the ground. I see a bunch of people in here that show signs of previous frustrations. Am I in the right place? Anybody in here ever been frustrated? Anybody in here ever not been frustrated? All right, am I losing you? Okay. What was I saying? I got a problem with short-term memory. I got MS. My short-term memory is not the best. And also, my short-term memory is pretty bad. So, I'm reaching, guys. Yeah. I need somebody to come up here and be my teammate. Come on, anybody. Not all at once. Come on. Pair up into groups of 3 and line up in a circle. Okay, let's see. How's that? Is that heavy?
Not too bad.
Not too bad. Okay, something simple that you can do. First off, you ever get frustrated, mad at anything?
At work all the time.
Okay, it works right here. Throw the ball right at that spot. Throw it. Now pick it up and do it with both hands. You'll have better aim and you'll get work right in the head. There you go. How'd that feel?
Good.
Yeah? Look, she made a pancake out of it too.
If I can do that to my coworker, that would be
Okay,
better.
now what I want you to do is I'm going to throw this to you and you throw that to me at the same time. Ready? 1, 2, 3, go. Again. Faster. Come on, let's go. Ah, you win. You win. That $10,000 check, he's got it.
Oh, okay.
Okay, but that's a little fun, a little bit somewhat. Okay, let's go. Keep it up.
Oh.
Okay, stand on one leg now.
Oh.
Uh-oh.
Having some issues.
Stand on the other leg. Stand on someone else's leg. Okay, but you see, you're getting a little bit winded?
Yeah.
Was it difficult?
Hurts today, so.
But was that tough?
No.
No. Was it fun?
Yeah.
I saw you smile. Anybody in here not see her smile? All right, you can sit down. Thank you. Now that's one thing that you can do with these. Now that's just a very simple thing. So if you have ones that bounce, you can bounce them back to each other. These are things that are fun for children of all ages. I don't do this with anyone over 103. Now, one of the best things about these is they're safe. When it comes to exercise, you have to have a safety factor. Now, if I were to drop this versus dropping a dumbbell and it landed on my foot, it might hurt a little bit. Not as bad as a dumbbell. These are sandbags. A 4-pound sandbag, that doesn't hurt at all. Not even if I let it drop on the foot, I can feel. I'm just kidding. I can feel both my feet. And you can too. Who wants to feel my feet? I just want to see you guys laugh a little bit. These medicine balls come in different sizes. That one's 5 pounds. I got a 2-pound ball. This is a 15-pound ball. And you can do a lot of similar things with these as you can with dumbbells or weights. You can do rows, presses, chandelier breaking. There's a lot of things that you can do with them. And the sandbags I have up to 10 pounds. They come up to 50 pounds. Who wants to feel this? I know you do. Throw it to me. Ow! No, it's pretty soft though, isn't it? Okay, so if you can't do it with the 10-pound one, you start with a 2 or a 3-pound one, and you just perform different activities with it. One is throwing it as far as you can. And that's something that works for cardiovascular exercise too, believe it or not. I'll tell you a story about a client of mine who's 92 years old right now, and I trained her twice a week for a long time. Up until recently, I still train her twice a week. She retired. I was going to her office at her lunch break. Twice a week. 92. And I asked her the first time how many times she can walk around the atrium. And she said, I can't make it around that one time. I said, have you ever tried? She said, no, but I know I can't. And I said, I know you can, and I'm going to prove to you that you can. So what I did was I got something like this. It was really a little beanbag, but I said, if you can't make it around the whole thing, can you at least throw this? So I said, throw it as far as you can. It's about how far it went. I said, okay, let's go get it. I said, I want to see you throw it a little bit further. And she's thinking, wow, I'm going to do better this time. I'm going to throw it even further. She threw it further. We got it. Couple minutes go by, we make it around to the beginning again. And I said, all right, now we made it around. She's like, all right, can we do it without throwing it now? I said, yeah, we're on. So what you have to do is you have to figure out a way. You find a way. There's always things in life that you can find a way to do. But if you get stuck looking for excuses to not do them, you won't do them. You know that saying, whether you think you can or you think you can't, you're right? You know, think about it, because I don't know who said it, but if it wasn't him, then I'm saying it. No. But it's the truth. If you think that you can do something and you believe in yourself, you're going to have better results.
I remember going to a speech one time where they handed out cans, and on the label on the can it said
There you go. Well, that's like, who's the famous philosopher of the 20th century that said, there's do and there's not do, but there's no try? Anyone know who that was? Yoda. Come on. Yoda did it. Yoda said that. Yoda could have worked for Nike. You know, just do it. That's the best slogan there is. Just do it. What else are you going to do? Just do it. So I'm going to move on to some other things over here. Exercise bands. Exercise bands are safe as well. Let me see. I'm going to need somebody. Can you see the door if I were to go do? Okay. These exercise bands are unique because you can lock them in a door. And then you don't have to have somebody really spotting you. And all it takes is a door with a door jamb, which most of them have. There, did everybody see that? No, I'm just kidding. You can't see anything from there. But I'm going to put this down and speak rather loud. All right. When you think about going to the gym, what do you think about? A bunch of weights and heavy lifting and grunting and all that kind of stuff, throwing around iron, right? Well, you can get a lot out of a band such as this, just like you can a bench press, except for the difference between doing this and doing a bench press. What I'm doing right now, my feet are my ground base of support. All the energy is coming from the ground up. Every muscle between there and up here has to do something to prevent me from falling down. So what I'm doing is I'm doing a bench press. This look like a bench press to you guys? Except instead of having a bench on my back to support me and not worry about my core is into it. So in order for me to do this without falling back, my abs have to be tight. Same thing goes if you're sitting in a chair. You can do all this stuff sitting in a chair. Same thing goes for a row. This is a row. Now what I'm doing is I'm working my back muscles primarily. Secondary, I'm working my biceps. But I'm also working my lower back. And I'm really strengthening my lower back by doing this because if I wasn't, I'd fall forward, just like the opposite of what the press was. And then you can do all kinds of stuff. You can do these. You can do curls with them. You can do some, this is an ab exercise, actually. It's like standing crunches. But there's so many different exercises that you can do with it. And one exercise is just holding it. This is a static exercise. Same thing as when I said I was doing the rows, working my lower back. Just holding it here is working my lower back. So now progressions in exercise, you got to make progressions as you're getting stronger or you're developing a skill. So what I like to do is I like to add rotation to exercises, level changes, add balance, because balance is important, but balance is meaningless without stability, because this is stability. Back to talking about sports. Is there any sport you could think of that's really a sport that doesn't have the ready position? None? They all do, right?
It's really a sport,
Yeah, I mean, I'm not going to, poker's not a sport. But it's on ESPN. All right, so now I'm going to move on to, I'll talk about the stability ball. Stability ball is something that you can do all those things that I was showing you while seated on it. You never want to stand on it. But when you're seated on a stability ball, watch, I'm looking at a bunch of people with bad posture right now. Okay, I'm looking at a lot of people with better posture now. And now it's starting to get bad again. Because posture is a habit. And if you make it a habit not to have bad posture, you won't have bad posture. It takes time. But if every time you see yourself doing this, you sit up, you've got the muscles for it. You've already got the muscles. Yeah, you can strengthen the muscles, but it's not going to remind you to sit up or stand up straight. And when you stand up and sit up straight, it's like everything else works a little bit better. You're not getting any compressions in your back and your shoulders and your neck. And it's the same thing as like someone who asked the question about food and diet with MS. There's so many diets out there. The best diets are the healthiest ones. You know, a diet's just what you eat. So if you eat garbage, you're going to end up feeling like garbage, looking like garbage, and ending up in the garbage at some point. So you want to eat well so that you can perform well. That's what it's all about. What you put in, what you eat is what you are. So eat better. If you ate like a diabetic should eat, not does eat, then you'd be a healthier person. And the healthier you are, and I think this goes, that you can attest to this, is if you have somebody who's really unhealthy with MS and they're always getting sick and their immune system is taxed all the time, wouldn't they have a more difficult time with their MS? Isn't that how it, I mean, and if it's not the case, you're going to be healthy. You know, that's the result. You want to be healthy. So what I was saying about balance and stability is like this. This does me no good except for I can join the circus, right? Now this doesn't, but I can do that, and you know what? It doesn't take me any effort to do it because it's learned. It's easy. My core muscles are actually loose when I'm sitting up on here like this, because the first 40 or 50,000 times I tried, they were getting stronger, and my body was able to. Now what I could do is I could do exercise. I could lift weights on one side. You know, if you do a unilateral sided exercise, you'll be working your core a lot. Like if I was doing that press just with one side, I'd be working my obliques without the motion in my obliques, so it wouldn't pull my body back. And that's really important to do, like a push-up. If you were able to do it, anyone here not able to do a push-up? A push-up doesn't have to be on the ground, going all the way, touch your nose to the ground, coming up. It could be up against the wall. But doing an exercise like this up against the wall, this isn't a wall, I know. And you were to come here and just push yourself back, that's strengthening this area of your body, these muscles. Now when you're walking and someone bumps into you and you do this and you fall down, that could be the difference of falling down and not. Or if you're turning a corner and it happens to me, you ever have the wall jump out at you and hit your shoulder? Oh, I don't know, they know I'm coming, the wall jumps out, boom, I catch my shoulder, and I didn't think that anybody else did it until I started going to support groups. And I think there should be support groups for banging your shoulder, because I got a really bad right shoulder now from it. Let's see. Now, some more traditional weights or things here. This is a body bar. It's a 15-pound bar. It's padded for protection so nobody really hurts himself with it. I like doing stuff with it, but I like to think outside of the box. Hey, what's the most important exercise equipment there is out there?
One that don't hurt you?
You. It's you. Yeah, yourself. You can do a whole workout without any equipment. And sometimes, you know, I fool around with my clients with the notion of you can pick anything and we can do a whole workout with it. And I've done it. I've done it where it's been something like this, a body bar, because a body bar you can do a one-arm press, you can do a two-arm press, you can do a row, you can do a squat, you can do a lunge. You can do all these different things and make it into a workout with just one thing. Or you take this away. I've done a whole workout with a balloon. I always keep a balloon in my pocket. Who's got my balloon?
What kind of balloon you're talking about?
The one in the wallet, you mean? All right, I don't have asthma. Anyone want to try? Okay, who's my volunteer? Come on, I need a volunteer. You. You with the smile. Not that you're not the only one smiling, but okay. Have a seat right there. Someone's got to start the music. I'm kidding. There's no music. Can you stand up? Can you stand up? Sit down. Now, can you do it like 40 times? No, I'm just kidding. I just wanted to see if you were confident. That's good. Confidence is important. Okay, what I want you to do is, think I'm going to throw it to you from there? I'm not. I'm going to do it from back here. I'm going to throw this, and you're going to have to get up and catch it. Okay? I'm really going to hit it, not throw it. Get up and catch it. Now come back and have a seat. Hand it to me. Go.
You want to hand it backwards to you?
Oh. You're supposed to stand up.
Oh.
I'm just kidding, but you see, what you just did was a bunch of squats.
Yeah.
Okay? With controlling your body, so you're working your core, so you don't come on. Now, if you have a partner to do that with, then you can have a whole workout with something like this. Now, I've had something where, here, hold this. Can you hold this? Don't talk into it. It's my show. No, I'm just kidding. Where I'd be here, now hit it. Hit it somewhere. So, and you have to get up and catch it before it lands. Now, something like that is a lot easier with a balloon, especially if you hit it up higher and made it easier enough for me. Come on, you know?
I'll do it again.
I'm tired
I'll
here.
do it again.
Do it again. Come on. But that's not easy to do, especially if you can't get up. So what I tell people is if you can't get up off the ground, maybe someday you will be able to, and then you're going to have to catch a balloon. But there's so many different things. Now, if I were to just hit it like you over there and you had to catch it, now let's say you couldn't get up. But now catch it, now throw it back to me. What you're doing is you have to control your core. You're not, so that you don't overreach for it. You see that? So that's a workout with a balloon. Ah, look at that. So if you can't grab it with two hands, then the goal would be to hit it with one. So pretend as though you can't use your right arm. And then hit it back. Now hit it. Now do it with your right arm. No, you can't move that arm. I'm just kidding. I'm just kidding. Okay, you can have a seat. Thanks. Now I've got some just these bouncy balls. These are just little bouncy balls. This is one with a smile. So, here. Ah, you see that? Now, do you have MS? No? Ah, it's figures. No, I'm just kidding. Do you have MS? Oh, come on. Anyone here have MS? Okay. No, I'm not going to throw it across the whole room. Who? Come on. Someone raise your hand with MS. Is that your good hand? Of course it is. Here. No, actually. It's not? Oh, you see, you know what the one thing that you can do with these that's dangerous? Here. Break a glass. You see? The nerve of you to have those glasses on the table. But if you think that MS is taking your abilities away, just try to catch a ball. You know how much thought goes into catching a ball? How many nerves have to work to do that? Rapid. I mean, it's like that, and you don't even think about it. It just happens, right? You see? Do you have MS? No. Oh, you see? You're going to get it now. No, it's good. There you go. Here. A lot easier than that heavy one, isn't it? A lot easier. Okay, Stuart. Oh, come on. He doesn't have it. Okay, so you see, something like this, it doesn't have to be restricted to a 4 or 5-year-old. You know, it can be restricted. You can use any. Oh, everyone, you're just going to watch? Okay. So that's something with these. Now, these are some things that have unstable surfaces. Now, the first unstable surface is just going to be this exercise mat. Just standing on this exercise mat is going to make me contract a lot more muscles because it's a soft surface. So proprioception is something that can be lacking with people with MS. Does anybody know what proprioception is? No. It's where you are in space and how your body determines where you are in space. So you've got like proprioceptors running through your body. So if you step without thinking, this is just, you're going to step if there was a rock on the ground. To prevent you from turning your ankle, it sends a signal to the next joint, to the next joint, to the brain, to the back to stabilize that foot. If you had no proprioception, you'd turn your ankle every time you didn't walk on a flat surface. So this is a little bit unstable. Anybody want to stand on it? Okay. You see him? He's standing on it. No. So what I would do is ready position. Always start at the ready position. To add balance to it, instead of just staying here, stagger stance a little bit more, keep your feet closer together, and then eventually to here. And if you fall back, you go back to here. Then you try it with the other leg. And then you have to test yourself. So let's say, do a stopwatch. I can only stand 10 seconds here. What's your goal? Well, the goal is to do it again and to do it a little bit better. And then you want to go for 11 seconds. If you can get 11 seconds, fine, go to 20 seconds. When you get to a minute, try the other leg and do it with that. But you keep trying and you keep challenging yourself. And that's where it becomes fun. That's where it becomes a progressive program. Because if you're okay with doing 10 pounds 10 times every time you go, you might maintain where you're at, but you're not going to get better. You're not going to become quicker, faster, stronger, or more efficient. So you want to challenge yourself by adding more weight. This is another unstable surface. This is going to a next level. Actually, the next one would be something like an RX pad. Who took my RX pad? It's in that pile of things I lost. Now this is more a little bit squishier, so it's a little bit more unstable, you see? So I wouldn't have you just start by standing on one leg on it, 2 feet. Even 2 feet with this while doing an upper body exercise, you're still getting some more work in your ankles. It's actually a good ankle rehab tool because by standing on it on 1 foot, you're working your ankle, the muscles around your ankles, your peroneal muscles and your tibialis anterior and all the other ones that are supporting you. This is the next level to that, something like this, to stand on with 1 foot. And it takes practice. And then something like this, a Bosu ball. Anybody used one of these before? Looks like one of those little needle cushions that they train you to do your injections with. This is a Bosu ball. It stands for both sides up. So you can do squats on this, and your legs will shake a lot because you're using your stabilizing muscles rather than your prime movers to keep you from doing that. And you go, to do a squat. And it's actually harder on this side. Whoop. And you can do squats on it. Now, if you can't sit on that stability ball, but you want to do an exercise on it, this is much more stable because it's got a flat surface. You can sit on this. If you can't see me, can you see my hands? I promise I'm sitting on the ball. To sit on this ball, and you can do ab work, you can do lower back work, you can do Superman type things. You can do push-ups on this. You can have them swayed to one side. But the goal is to increase what you're doing a little bit at a time. And you know what happens if you have MS and you have an exacerbation or a setback? You start over. You don't give up. There's no room for giving up. And especially for you guys in this room because you made it here. The people that didn't make it here are the ones that probably needed a little bit more than you. Because they'll never know what we did. I could have passed out those $10,000 checks. It would have been great until you cashed them. Now I got something like this, which is good for shoulder stability. This is a toy. It's probably seen it in the middle of the night. You ever seen these on television? No, it's a body blade. It's difficult. I mean, anybody want to try? You don't have to come up to do it. Who wants to give it a shot? Who? All right. Who? The cameras can't see him, but he's doing it great.
That's not what you're supposed to do with it?
Yeah. It's strengthening the stabilizing muscles in your shoulder when you do that. But you can also do stuff like curls, like the shake weights. I'll give you my rundown on the shake weights. Anyone in here use them?
Tried it.
The best thing about those is if you're going to use them versus not using anything. But they're not going to do any more for you than the actual weight. But it's cool. If it's on the middle of the night and you're not willing to do it in the middle of the night, don't get it.
That's a good theory.
Because all these things that you buy that are sold to make things look easy, you're going to get them and you're going to have to do work. And unless you're awake watching it, that's when you're motivated. If you're going to do it at 2, 3 o'clock in the morning, great. If not, it's going to sit next to the treadmill with your suit and your clothes and all that stuff hanging on it. Now, I'll tell you what I also like to do is when with people with MS, the core temperature gets up. By the way, the indoor recommended temperatures for exercise are 66 to 70 degrees Fahrenheit for people with MS. And for people who don't have MS, it's 66 to 74 degrees. Those are numbers by the American College of Sports Medicine. So keep it cool when you're exercising. You'll have a lot better results. You'll have more energy. Your core temperature won't rise with the heat. But what I like to do with people that, even people who have MS, when I give them something to do, what do you do after a set? You just sit there? You look around the gym, you see someone doing some really hard exercise, and then they're doing this. That's time. You do not get time back, right? Time is one thing that you get one shot at. It doesn't come back to you. So utilize the time you have. So if you're at the gym, you do a set of a shoulder exercise or whatever it is that you're going to do, why not take a break like this? Use that time to do something that's going to be helpful rather than, he may as well be text messaging like the next people that are over there. But what I like to do is, give them some kind of a balance thing or some kind of a rotational movement to do, something to keep them moving, something to keep them busy, something to help their balance. Do whatever you can to get them active in the workout. And if they can't do that, then you give them a break and you quiz them. What's 18 times 4 divided by 3? Or like, can you count backwards in multiples of 7.43 from 100? Okay, and if someone really, by the time they figure out the first one, then okay, you do the next set. But that's a good thing to do because cognition is an issue. So that's something that I have to talk to people about while I'm teaching them an exercise. Do you remember what you're doing? This is what it's supposed to look like. This is a squat. Go ahead. Now we're going to do 10 of those. You have to keep doing that because the worst thing that can happen is you tell them to do a squat and they look at you and they think, oh my gosh, I'm really feeling stupid right now. What's a squat? I'm going to do it wrong. I'm just not going to do it all. You lose them and they're gone. So I like to show them the exercise, say the name of it, demonstrate it, and then let them do it. And also, if you're doing an upper body exercise, your upper body's tired, why not follow it with a lower body exercise while your upper body? If it's a cardiorespiratory or a cardiovascular problem that you're having where you're not in shape, then you need to get in a little bit better shape. Because that goes back to the biggest thing that causes fatigue in people with MS, I think, well, obviously the fatigue associated with MS, but lack of doing anything. Using those 112 extra hours after the sleep you had to be thinking rather than doing. So I'm challenging you guys to do something, rather than complain. You can complain. You can put a couple hours aside to complain. It's all right. But for every hour or minute that you complain, throw something positive to combat it, to counter it. Because you got a lot of time on your hands. And I know that it's not easy to get through the day sometimes, but you find the time that's best to exercise and you tackle it. Okay. Any questions? Yep. Okay, what he asked is, he said he had a doctor that I guess was kind of old school. He had a little bit old school in theories and thoughts. Well, that said, it's not good to exercise because MS will...
It goes deeper into your muscles.
Yeah, but MS isn't really in your muscles. I guess it kind of isn't everywhere in your body. But it's going to affect your nerves. I don't know. I mean, I don't know the doctor. I don't know if it's your specific case. But I don't know of any doctors currently that advise against exercise with MS unless you have something like a autonomic nervous problem.
It's just changed in the last few years.
It's been, when I was diagnosed 15 years ago, I had one doctor that told me not to exercise, and I saw him once. And then all the rest of the doctors said, if you don't exercise, you're losing out. Exercise, and maybe that doctor is referring to vigorous exercise, but when it just comes to exercise, and if he's telling you not to exercise, I don't want to say anything bad about the doctor, so I'm not going to. The stats and the numbers and the research says exercise is important at the right levels. In fact, it's very helpful.
You know, it's just MS is it's just come out in what 1990 or 90 or 85. MS is actually a pretty new.
No, MS came out in the 1800s. MS
well, I
was
mean, they
first,
just found out about it. No.
They just named it.
Yeah. Well, no, it was compared to Parkinson's in I think what the 1880s was it or the and there's a difference between the two that they found out in autopsies and whatnot, but MS has been around a lot longer than we have.
Well, I mean, you know, there's a lot of debate about that. But.
If well, I'm sorry, I missed that.
My uncle got it in the 30s.
Mm-hmm.
Same time that baseball player got it.
Okay.
Lou Gehrig.
Got it when he got ALS.
They were sitting side by side. Uncle Floyd was the lucky one. He fished every day of his life, carried his boat to the river.
Yep. Well, it's been around a long time, and it's it's not a new disease. The research and the disease-modifying drugs are fairly new. But for my particular cases, I take medicine because it's indicated for the MS that I have, and like what the MS Society says, if there's a medicine out there for you, for the type of MS you have, get on it, find the one that works for you, and stay with it. And that's what I do. And every single day, I take my shot. I eat breakfast, I eat lunch, I eat dinner, I try to get a good night's sleep, and here I am standing before you, which at one point I never thought would happen. So. You guys help me as much as I'm helping you, maybe more. So thank you guys for coming out. Well, who's got a question? You got a question?
When we do exercise for people that wear any kind of device, would you recommend that you wear it at the time or you not?
What kind of device? Like an AFO?
Yeah.
Yeah. Well, it depends. If you're
for the ankles and stuff
well,
like that.
You see, what the types of exercises you do the results you're going to get are going to be based on how you're doing your exercises. So if you're going to be performing on a daily basis with that,
it's not going to strengthen that.
No, then you exercise with that on, or you may not be able to get the most out of your exercise. Yeah, you should do some stuff on the side for that, so you don't.
It's not going to strengthen my ankle.
Yeah. I mean, just standing on something like this, with or without that's going to strengthen your ankle.
With or without.
With or without it, yeah.
Okay.
All right.
Thank you again.
So we get to clap for Jeff again. And I'd like to thank Jeff because I think now, since we started having Jeff come around and do programs, I think this is the 8th program in less than a year. So I'm very happy he does this because I know that what he's doing is going to benefit at least one of you. Okay? And that's all we wanted to do is benefit somebody. So listen, I want to thank you all for coming tonight, but we do have one more thing to do, don't we? We have a raffle. So I'm going to ask Maida, who's in the back of the room, and Maida is a volunteer for MS Views and News. She comes out to a lot of our programs in Central Florida, and she comes out and she helps us out with registrations or picking raffle tickets. You couldn't find a bigger ball? There's plenty around here. Oh, a bowl. Must be that accent. You could draw.
All right. Let's see. 884549.
Now, she did it wrong. Well, thank you, 884549, for coming tonight. And I want to thank you all for coming on out here, and we hope that you're watching the information that we're providing, whether it be on our YouTube channel or receiving the information that we provide via the internet, the newsletter, and whatever else that we have going on out there. If you ever have a question for us to ask to a medical professional, we do have a medical advisory board. So whether it be MS-related, orthopedic, psychological, urological, whatever, one of those guys, we do have that too. In fact, we're doing a program in Ocala on February 22nd with a financial advisor. And this program is the impact of MS on the family. So that way, it's financial rights for the patient and the caregivers, what they're allowed to actually get away with in the state of Florida. You'll be surprised at what you're not entitled to.
Yeah, I wouldn't surprise you.
You'll be very surprised to see what you're not entitled to. So we have this attorney that's also part of MS Views and News. and he does go around and do these programs for us as well. So again, anything that you want, have a question for, I'm not going to answer it. We're going to put it to one of our advisors, and we can get back with you, to you on that answer. I don't have to see it. If you want me to have that person just write to you directly, that can happen as well. Okay? Thank you again for coming out tonight, and have a great night.